Okay, so we're going to take a look through it. We're going to do that with a couple of things in mind. One, that our module topic is meaningful use, right? Appraise the past, present, and future directions of meaningful use. And meaningful use in its simplest form means how do we make the EHR more meaningful and useful? And so it's the government's attempt to set out specifications and initiatives tied to payment for facilitating that process. The second thing we want to keep in mind is that we read in the Niles text about public health's role and the U.S. healthcare workforce. So those three things together, like how do they mesh? Well, there's this idea that we also read about in the short-lived text called clinical decision support systems. And so if we were to take the influence of public health, the ways that we can influence public health, the influence of the U.S. healthcare force, the ways that we can use the U.S. healthcare workforce, and bring in clinical decision support systems and tools and put meaningful use over the top of them, what results? Well, what we see is this active and passive use of the EHR. So we have passive use up here, active use on the bottom, and what we want, this target, is here in this combination of both. So we have three columns. We have sample sizes that we'll look at, challenges, and common applications. So let's start in the active use with applications. So we have interventions that we might introduce into a population. For instance, maybe we want to treat a group of diabetics in a practice, and this particular group, we want to put them through wellness coaching and diet and nutrition support, and the other group, we're just going to monitor them with medication. And then an example of clinical decision support tools might be we associate cost with treatment options for patients, and so we give them the choice and have that conversation there with your physician about which choice you're going to make based on introducing the cost element as well. So what are some common challenges with these types of applications? Well, in any intervention we have to put it through the internal or institutional review board. So there's governance, right? Governing how it's going to happen, when it's going to happen, who's going to control what happens, where does the data go, how does it work? There's all sorts of questions that have to be asked and answered about governance. With clinical decision support tools, we have an issue with utilization. Most clinical decision support tools are aimed at the physician, for the physician to use them. So we're going to one of the most overburdened levels of our U.S. healthcare workforce to try to put these very highly sophisticated, sometimes, clinical decision support systems. So that's a challenge. How do we get them to use it when they're already busy to the max? Sample sizes. So if it's an intervention, it's usually approved for small numbers of people. And even if it's a clinical decision support tool, it has to have a physician champion and buy-in, so we're talking about smaller sample sizes. So all these are active uses of the EHR. They don't normally produce statistically significant results, and they're hard to replicate. So that's the active layer. Now let's talk about passive layer. This is more your population level research. So let's start with the applications. This is when we're looking at millions of people's data, right? It might be genomic data, and we're looking for biomarkers. We're looking for associations. We're looking at drug-to-drug interactions, all sorts of things on a bio level, right? We might also be looking at prevalence estimates. So again, remember, think we're in the EHR land, right? So, and just to make another connection for the biomarker, we might be combining genomic data with EHR data. So how do we do that? Prevalence estimates. So let's refresh our memory, or let's educate ourselves about what prevalence means. I'll give you an example. If you were to walk into a room and you were to ask, how many people in here have diabetes? However the number raised their hand, that's your prevalence estimate. It's how many people are estimated to have a certain condition in a population. So it helps you understand the burden of a disease or a condition. So you can look retrospectively or cross-sectionally at EHR data, and you can do prevalence estimates. So what's a challenge with these? Well, when you're dealing with genomic data and EHR data, you've got some serious data integration problems, for example. And if you're dealing with prevalence estimates, you have some validity issues, like how valid is the data that you're using? What are our sample sizes like? We talked about it in the millions, right? Maybe a million maybe several million. So you can pull data out, but you can't shove it back in. You can't put it back in. If you want to put data into the EHR, you have to go on these lower level ones. Lower level is in sample size. So where we want to really aim is in the middle, where we have both. So we want best practice alerts, but we want to avoid the challenge of alert fatigue. So this is where we start to really explore our public health systems and our U.S. healthcare workforce other than just the physician. Where can we put these best practice alerts where they might be functional and they might help and they are using the EHR data, but we're not doing it in a way that's overburdening the physician? How do we spread the love across the workforce, across the different perspectives? So in public health, that might mean surgenomic surveillance, right? So maybe we've have the EHR flag when a certain number of people into a practice come with certain stomach complaints or cramps, or going through ED departments. They have this where it flags, or it says, hey, maybe we have a food poisoning outbreak or a water contamination outbreak. Maybe we talk about screening algorithms, right? So maybe we build algorithms to look for certain things that flag somebody before they get to a physician or after they're done with a physician. Maybe screening algorithms related to payment, medication refills, or testing pain levels before you get to the physician. These are screening algorithms. So a challenge there might be, how do you, if you built something like that or you built that screening algorithm, how do you get it embedded in the EHR or the EMR? How do you get that access in there to put that data in there? So our sample sizes would get much bigger here, between 10,000 and 100,000, which means we would have enough that if we had effects between groups, if we designed a good study, we could detect statistically significant results if they existed. So while this is not a one category meets all, it's just meant to be a nice visual representation about how we can look at the active initiatives related to meaningful use, what kind of things are we trying to, where are we trying to implement these things, and the largest data tool or data source that we really have to deal with right now, which in a lot of ways is the EHR. So hopefully that's helpful and you can use that towards putting together your questions for your portfolio assignment this week.